Hi guys! Today we're going to show you a video of filling out the mother-baby data tool for Professor Tabor. So this is just a video going through what you already have online as a tool, but we're going in depth into things that you should be filling out and things that Professor Tabor will tell you after your first data tool collection. So that way you just have another form of being able to look at how to fill things out in a better way so that you can be more successful. So basically what you really need to know is that you can never put just within normal limits like a med-surg patient. For all your documentation, it's your responsibility to know what the vocabulary means. If you document that there are no abnormals because you don't know what they mean, you're putting the patient at risk for things and you could be forging medical documents. So this is why it's really important to have good documentation right off the bat. So starting out in the maternal assessment, you want to make sure you fill in all your vital signs. You need to know why you're doing that because you're establishing the patient baseline. Then you move on to the second column and you want to go into the topics that you're teaching your patient. So these things include what might be the appropriate self-care topics to include here. Consider their temperature. What should their temperature range be? What does it mean if they have a fever? What would that value be as a reportable number? What is the temperature that would suggest an infection possibly in the mom? What you want to do is also teach the mom if they are seeking medical care for if they do have a fever, who should they go see postpartum or once they leave the hospital. You could teach the mom for signs of drops in blood pressure if they're standing up, if they start to feel dizzy, and if their blood pressure is more than or less than 20% of their original baseline. That's why it's important to be taking their vitals in the first place. Then you would always move on to abnormal values as well and the significance of these findings. So you're not going to always have abnormals. Moms are pregnant and they are healthy. It's not like on a med-surg floor where you're looking for problems and then picking diagnoses off of a specific problem. You might not have abnormal values, but you need to talk about why they're not abnormal and what that means for the patient, the significance of those vital sign changes. So is the mom tachycardic? And if she's not, you need to state that she's not tachycardic. Is she hypotensive? How would you determine if she is hypotensive? You need to know the baseline. If not, you need to state that there is no hypotension. Also look at her pulses. If she had a rapid pulse, example over 120 beats per minute, it could be because she's compensating for a low blood pressure, which would mean problems for the mom. Is she hypertensive? Is she febrile? You need to be processing the data that you get from these vital signs and explaining to Professor Tabor why they are the way they are. Anybody can fill in blanks and copy data, but as a nurse, you need to be able to process the data that you're getting. So then you can move on to the mental assessment. This can be done in a couple different ways, but mainly you want to be looking at maternal bonding. Again, this isn't a med-surg patient, so you don't necessarily need to say that the mom is alert and oriented person, place, and time times 3, because she should be able to do so. Mental assessments can include topics on postpartum depression, on the baby blues, bonding with the newborn, if they're holding the newborn, if they have family present, if they have a good support system. So those are all things that you'll include in the mental assessment and if your facility does depression scales. So for topics taught, you teach about postpartum depression and signs that she should be looking for as she leaves the hospital, and also that what is normal for baby blues. And again, these topics aren't going to be taught in this video, and if you don't know what some of the terms are, it's important to go look those up. Moving on to abnormal values and significance for mental assessments, you want to ask yourself questions of, is she participating in the care of self and newborn? Or what evidence of maternal bonding did you witness while you were there? So was the mother holding the baby? Was she breastfeeding? Was their family present? You want to write down what you found while you were there and what that means for that patient.
The only reason that you would look at or state that a patient is alert and oriented times 3 or really talk about any med-surg aspects of mental assessments would be if you have a mom that has a reason for those things to be assessed, like if she's a seizure risk or if she had a complication during labor or delivery that caused her to pass out, then yes, like assessing whether she's awake and alert and oriented would be important. But otherwise, most moms come in healthy. They're just pregnant. It's not a disease. So you wouldn't be assessing to make sure that they're awake and oriented, because you're going to be awake when you're having a baby.
Exactly. So then, again, it's always important to get your baseline assessments, and that's why you always go into a patient's room and you listen to their heart, lungs, and bowel sounds when you go onto the auscultation section. So you want to mention your findings, if what the heart sounds were, if the bowel sounds were present, and if the lung sounds were clear. Some teaching topics for the mother for auscultation would be why you're continuously doing these assessments, and because patients don't always know why you're going into the room and constantly listening to their heart and lungs. So you just mention that you're listening for any changes and just making sure that the mom's continuing to be healthy as she progresses through the postpartum phase.
A lot of moms will get nervous if you're doing an assessment over and over and you don't explain why, because they think that something's wrong. You have to remember they're not sick, so they don't understand the precautions that we take or necessarily why we're taking them. And another teaching topic, I don't know if Madalyn mentioned this, but especially for post-op moms, so C-section mamas, they are at an increased risk for constipation. So listening to their bowel sounds is really important.
Definitely. You need to also document on this form whether they were vaginal or cesarean delivery. We're currently documenting for a vaginal delivery, but there's certain sections that will mention things that are significant for C-section moms. So for abnormal values, something abnormal but something that's very common is that a mom will take Colace after delivery in order to help the bowels move. Then with taking that Colace, you need to talk about if she is at risk for constipation related to those meds, if she's at risk for then diarrhea and vice versa. You need to think about the risks for mom with the medication she's taking, whether that be for heart as well. You need to consider all the things that the mom has going on. Then, as you know, you're always going to assess the breasts. This was important for our mom specifically that we're filling out for today because she's a first-time mom, and we know that breastfeeding is sometimes very difficult. So as Corynne's filling that out, you want to make sure you actually document what you did. You never want to document something that you didn't do. So you want to feel the breasts to make sure they're soft, firm, or engorged. So that way you're having correct documentation, and then noting the nipples and the latch score if you did that. So for the topics taught, you want to consider bedside assistance with breastfeeding, if somebody was there to help her, if the nurse was assisting, or if lactation was there. If they need help with positioning, what the early feeding cues are for the infant is really important. You could also teach how you know if the baby's getting enough, if the baby has any weight loss, if they have weight gain. And you also want to talk about symptoms of mastitis, and also what is dry breast care for those who are not breastfeeding. So you need to talk about what's significant for your mom. So our mom, for example, her breasts were soft and prominent, but her latch score was an 8 out of 10 because she needed to use a nipple shield. She was having difficulty breastfeeding a little bit for her first time. So that's important to document in case in the future she has another baby and wants to remember what she did.
And with nipple shield, you need to note the size that they're using. They come in different sizes, and also the type. Some of them are more extroverted than others, depending on the mom's needs. Did you mention mastitis?
Mm-hmm.
Awesome.
So you need to teach the moms to look out for symptoms because breastfeeding is kind of hard on the nipples. So moms will often ask, why are my nipples dry? You need to teach them what's normal after delivery and what's abnormal. If there is scarring, if there is any bleeding or any severe dryness, and then how to prevent that in the future are also teaching points. This is why it's really important to listen in on lactation consultants if you have a patient. So then for those abnormal values, again, you want to assign the latch score. Ask the mom about comfort with processing and analyzing the breastfeeding log to make sure the baby is getting enough. So mom will get a documentation tool, and it's your job to make sure that she's filling it out and then to document those values as the nurse. So you need to teach the mom, how do you know if the baby's getting enough? And then we know that assessing the uterus is very, 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 very important. So Corynne will go ahead and make those documentations of what she found when she palpated the uterus. So you definitely need to check this and then note what you found. You need to note if it was offset, if it was to the side, if it was too high, and if it was boggy. These are very important topics and you need to know why. So at what time this mom delivered and how far after postpartum she is will depend on where her uterus should be. So for this documentation, we would write what is the expected descent of the fundus, when is the cervix technically considered closed, and you need to talk about the importance of voiding frequently and what can happen if the bladder is full, what can happen to that uterus. Those are teaching topics for the mom. For abnormals, if the uterus is boggy, we know that that is abnormal and significant. You need to note if there's evidence of an atonic uterus or heavy bleeding. You also want to talk about the evidence of subinvolution. So although there was no abnormality with this mom's uterus, we need to talk about why there's no abnormality. I mean, it's not boggy, meaning that there's currently no risk for postpartum hemorrhage related to the uterus.
And if you're ever not sure if you should include something, you're better off to just include it. You would rather be overly thorough than not thorough enough, especially because these tools are basically being used to paint a picture. Professor Tabor will always tell you she wants to hear your mom's story. So a story takes some descriptions, and you're better off to just include as much as you can about that mom and what her current status is and what her struggles are versus leaving something important out.
Exactly. So moving on to the bladder under the uterus. We just had our documentation spread out for your purposes. You need to document whether the bladder was non-distended, distended, or if she voids freely. Voiding freely also means not with a catheter, so you need to document if she still has a catheter in place or if she's voiding spontaneously.
Yeah, so on this sheet it talks about voiding freely, but Professor Tabor will tell you that a void means that it's spontaneous, which is why it says freely. If they are using a catheter or an in and out cath, it is not a void, it is output. And that's just something to keep in mind, because if you get those mixed, she will call you out on it. They're only voiding if they're able to do it on their own.
So you need to document exactly what it was. That's why documentation is important, and what you say depicts what actually happened. For teaching, you want to teach mom the importance of emptying the bladder, because sometimes it's not fun to get up. Moms don't want to get up right away. They're tired. They just had a baby. But you need to know and teach them why it's important to get up and go to the bathroom and why we need to check those voids. You also want to teach about symptoms of UTIs, and if they do have any burning sensations, they need to be able to report that to you.
And one thing I like to include to moms while I'm teaching them about their bladder and their voiding is that we want them to have an output, or we want them to void at least 30 milliliters an hour. So if they're not doing that, that's a real concern. And there are different rules and regulations when they're a post C-section mom, but you will learn those, and once you know them, you would also want to make note of things like when or if their catheter had been taken out, how much they had in output versus voiding, those kinds of things.
So for in our example, in our documentation, the bladder was non-distended and she's currently voiding freely. So we would document those values as spontaneous voiding without evidence of UTI or incomplete emptying and no urinary retention. But for example, if you did have a mom who had a distended bladder, you would need to write in that abnormal what that means. What does that mean for that mom? What do you need to then do? Does she need to have an in and out catheter? You need to document that. You need to document what interventions will then take place for the future and what she may be at risk for with that urinary retention. And moving on to the bottom. So for our specific mom, she did have some swelling at the bottom. This was due to a 3rd-degree laceration. So this is a location where you're continuing to tell the mom's story. So for our mom, we included a laceration, and you'll need to include what degree that was and what that means for your mom, including pain more so down at the bottom. You want to teach then about the bottom with self-comfort care, importance of teaching wiping front to back, if they're using a peri bottle to help rinse, and then about changing their pad each time they do go to the bathroom. This is also a really good area to start teaching about Kegel exercises and what does that do for the mom, and then how does she do them. All those things that you're teaching the moms out loud and what the nurse is teaching the moms when you're there and what you observe, this is where you get to document that. This is where you get to prove that you're smart and that you studied. Again, for the bottom, for abnormal values, you would also document here if they're taking Colace, because that will change some things for the bottom. If it was a 3rd degree or 4th degree laceration, it could be a possible hematoma formation. And you also want to emphasize infection prevention here, because the bottom is a problem for a lot of adults, even in med-surg patients. So this is where you do get to get a little bit of your med-surg care plan use here.
And with our mom, she had an LGA baby, so a large for gestational age baby, which means that in this abnormal section, I'm going to relate her swelling and her 3rd degree laceration to that. I'm going to try to help explain that part of her story and explain why she has these abnormal findings. And if you don't know, feel free to ask your nurse or look it up in their chart. Just don't document it if you don't know it. And we're noting that she has stitches present because she has a 3rd degree laceration.
And if her pain is then later on related to the laceration pain, you want to mention that. Or if it's pain in the abdomen, these are things that are continuing to tell the mom's story. So moving on to the lochia. This is important for you to know and specify based on how many hours postpartum this mom is, because it will be different and which day postpartum she is. So we documented her as rubra and scant. So you have to look at the pad. These are things you have to look at while you're there at time in clinical. You also want to ask the mom questions. Ask what she's seen. Ask what she's been like the day before or the day of before you got there. You want to ask the mom what she's seeing down there, and if she has any questions, you always want to ask the mom. OB is a lot of education to the patients. So for the topics taught, you want to teach moms about postpartum hemorrhage. They need to be looking out for how much blood coming out is too much. They also need to be taught what is expected. What is expected normal bleeding postpartum? What is unexpected if there are clots? What clot size specifically is too big or too small? For your abnormal values, you need to put if there was any clots, this is where you document them, and then what that would mean for the patient. Is she then at risk for a postpartum hemorrhage? If not, then you need to state that she is not at risk for postpartum hemorrhage, or that there is no evidence currently of a postpartum hemorrhage.
And we describe a postpartum hemorrhage differently depending on whether the mom was a vaginal birth or a cesarean. And for our mom, since she had a vaginal delivery, postpartum hemorrhage would be anything greater than 500 milliliters of estimated blood loss. So in my abnormal section, I'm going to document that she had less than 500 milliliters of estimated blood loss. And if you know the exact amount, that's great. If you don't document it. Don't make it up.
And some of these values too, you may not get at your time at clinical, but if you do have a chance to look at the chart or do have a chance to ask your nurse from the chart, what was the EBL, what was her hemoglobin, pre and postpartum, these are things you can always look up in the chart too. So moving on to the E in the mnemonic is edema. So these are things that you always need to look at for the mom. So a lot of times moms are swollen, and that's perfectly okay, but you do still need to document it, because if there's a change in the baseline, it could be significant. So you need to talk about why are moms normally swollen. This would also be a really good time to teach mom about the daily shower importance related to the maternal fluid shifts. Why are their feet kind of puffy? What is the maternal fluid volume shift? These are things that you need to look up and then discuss. So for the significance of the findings, where did you assess? You may talk about what is the difference between dependent and independent edema, or what kind is more concerning. At what point would you then be concerned with the mom?
You can also, for this mom, for example, she had +1 non-pitting edema in her ankles bilaterally. So I'm going to write that her tibial pulses were +2 so that you know that even though she has edema, it doesn't seem to be cutting off any circulation in that area.
So then moving on to the H and the Hamann sign. So this is another assessment that you need to do. So typically you'll find that the Hamann sign was negative, and you need to write what that means, how you determined that was negative, and what does it mean for the mom. So for the topics related to the Hamann sign, you can talk about the importance of ambulation, what are symptoms related to a positive Hamann sign that the mom cannot ignore, and why are moms more vulnerable to clots. So in your significance of findings or abnormal values, you need to think about what is the big concern if you do have a Hamann sign, and that would be that there's no signs of deep vein thrombosis.
If at any time we're talking about something, I know maternal fluid volume shifts, you might not know what we mean or know the parameters to that issue, make sure that you look these up. If you're going to write that it's something that you would teach that mom about, you need to actually be able to teach about that subject. So make sure that you are looking up the information. Our job is not to teach that to you, but we want you to be able to document it correctly and to have that as a tool to give to your patients.
So moving on to pain, these are always things you have to ask the mom. You can't just assume, and you always need to have their desired score prior to that. You need to ask that mom on a scale of 0 to 10 what her current pain is and what that pain is related to, whether it be a laceration, abdominal pain, etc. You need to talk about non-pharmaceutical options and also medication options. What does that mom have in her chart that she can take? What is significant related to those medications? And then you also need to talk about what interventions you did for that pain score. If the pain score was 0, you're still going to be teaching about non-pharmaceutical options because there may be pain in the future. Things that she can look out for, what she can expect once she leaves the hospital and can't ask those questions as easily. So you need to document if you did give any medications or if you did give any non-pharmaceutical care. You need to document your follow-up for those interventions, whether it be 30 minutes or an hour. What was that score after your intervention and what did you do?
So here, you want to be specific. I documented that she was administered 800 milligrams of ibuprofen by mouth for a pain of 6 out of 10 on the pain scale. And I'm going to go back and say that she had a pain score of 3 out of 10. And you want to include times. Always reassess your pain after you perform any pain intervention, even if it's not medication, even if it's just shifting them around in bed or giving them a foot massage or giving them a cold washcloth. You want to make sure you know if your intervention is actually working for them.
Okay, so moving on to the knowledge level, this is the last part of the maternal documentation. You want to talk about if the teaching plan was completed, and we're not going to do that because our mom was only 1 day postpartum. So her teaching was not done because she still has another day at the hospital. So you only write and check if the teaching plan is done, if they have gone to the last day of care here at the hospital, because a day 1 mom, postpartum, has not received all the teaching yet before she will go home. So for topics taught, you want to know, is she independent in self and newborn care? This would also be a good place to talk about if she is a first-time mom or if she's an experienced mom. These are reporting things that also help tell the mom's story and for the next nurse if you're giving a shift report. So our mother was RH negative. So this is a big teaching point for mom in case there might be some interventions that you need to look up that she will be getting possibly because of being RH negative. So then again, in the significance of the findings, was the teaching plan completed? Does she fully understand all the teaching that you did? Is she able to verbalize things back with you? Use teach back method if appropriate, all things that are important.
And we also have at IU North, we have a teaching tool. This is new this year in 2016, and it's called Understanding Mother and Baby Care. And this is given out to moms on the postpartum floor, and it has all kinds of resources for them, including numbers at which to contact different caretakers and options in the hospital, but also everything from what to expect for the first couple of days to how your newborn could look to what's normal and abnormal. It really just covers all of the teaching. This doesn't just eliminate your job of teaching the patient, but it does act as a tool for you to use. So if you're ever unsure for your teaching care topic of your data tool, what to put in there, grab one of these and take a look at it, because it'll give you some good ideas on what you could or should be teaching your patient about related to postpartum care.
Okay, so then we're going to move on to the last and final page of documentation, which is the second page of your normal sheet that you'll print out and take to clinical. So we're not doing documentation on a C-section mom, but you may have one. So there's a section that's called additional information for cesarean delivery of the client. And these are all things that you need to document and chart, and what would be abnormal versus normal. You cannot just write within normal limits again. So remember that you need to be putting notes on there what that means for the mom. Then you also do the newborn assessment. It's important that you know the vocabulary. You need to know what all these words mean in here. You can't circle something or not circle something just because you do not know what it means. Up by the vital signs where it says significance of findings. A lot of times this is hard for students to fill out, but you need to note if all those newborn vitals were within the ranges that are appropriate. You need to write whether they were tachypnic, whether they were tachycardic. Did they have any increased work of breathing? You need to process the data. No tachypnea, no bradycardia, no cold stress related to that temperature. You need to basically be talking about, is this newborn transitioning? And then, as you know, you'll fill out the newborn assessment by circling things. Again, the most important thing we can tell you, we're not going to go through it all, is just that you need to know the vocab. One thing that we also want to point out is that you won't circle something if you did not do it. If you didn't feel the pulses of the newborn, you're not going to circle it. So for example, we were not able to feel the newborn's pulses due to time constraints on that specific day. So we're not going to document it. You did not complete it. It is unethical and falsifying a medical record. Same thing goes for the umbilical cord. If the umbilical cord, for example, is very dry and it's almost falling off, you're not going to be able to see if that was a 3-vessel cord or not, so you won't document that. Again, we just want to reiterate that it's your responsibility to know what all this vocabulary means. If you document that there are no abnormals because you don't know what they mean, you're putting the patient at risk. This is your documentation. It's really important, and we're really happy that we get to help you do it all.
Yeah. And just quick side notes, your newborn vital sign ranges are all at the back of this page. So if you ever forget them, make sure you take a look at that so that you know right off the bat if your baby is not acting the way that they should. And also at IU Health North, they specifically use the FLAC score for pain. So you won't use NIPS at that facility, but you may use it somewhere else.
So again, if you ever have any questions, please utilize the senior students, ask questions to older students, and always email Professor Tabor if you have any questions on documentation. It's important, but you guys are going to learn it, and you're going to do great. Good luck.
Good luck.